Welcome everybody to this webinar on swallowing difficulties in neuromuscular disorders that is delivered by Professor Marianne de Visser. She needs no introduction. She's a very known person in the field and distinguished member of the Amsterdam faculty in the Academic Medical Center Amsterdam. And we know that that is a very important theme in neuromuscular disorders, one that usually causes many admissions to hospital, that is very much implicated in directed procedures to improve the quality of life of patients. And we are all very interested in the subject, and this is one of the basic webinars that the URN is organizing exactly to cover for important themes like this. And I thank Professor de Visser for her kind acceptance to do this webinar. Thank you, Marianne. The floor is yours.
Thank you, Antonio. Thank you for your kind words and for the introduction to this webinar on dysphagia. Well, what's happening now? These are my disclosures, but they are not relevant for this presentation. The word dysphagia is derived from the Greek phagein, which means to eat, and thus this with difficulty. So actually, dysphagia is the sensation of food being hindered in its normal passage from the mouth to the stomach. There are two distinct syndromes, oropharyngeal dysphagia and esophageal dysphagia. And this afternoon, we will confine ourselves to the oropharyngeal dysphagia, which is produced by abnormalities affecting the neuromuscular mechanism of the striated muscle of the mouth, pharynx, and upper esophageal sphincter. So we will not discuss the dysphagia, which is caused by the variety of disorders affecting the smooth muscle esophagus. Swallowing is a very complex, multifaceted process involving a variety of muscles and nerves. It is the starting point for the peristaltic transport of food to the stomach. There are three distinct phases which can be distinguished: the oral phase, the pharyngeal phase, and the esophageal phase, of which the first one is voluntary and the other two are reflex actions. The oral phase further divides into an oral preparatory phase and an oral propulsive phase. The location of the food bolus defines each of these phases as it descends towards the stomach. The oral and pharyngeal stages of swallowing share anatomy with the respiratory tract, so protection of the airway is of utmost importance. The oral preparatory stage begins when food or liquid enters the oral cavity. When drinking liquids, the posterior tongue rises to meet the soft palate to ensure a proper seal, preventing leakage of liquid oral cavity contents into the oral pharynx before the swallow initiates voluntarily. This seal does not form between the palate and tongue during the mastication of solid foods, and therefore free communication between the oral cavity and oral pharynx is preserved. Immediately before the initiation of a swallow, the anterior tongue rises to meet the hard palate as the posterior tongue drops and opens the oral pharynx. The bolus is then propelled down the palate by the tongue towards the oral pharynx, and this is the oral propulsive stage. The pharyngeal stage occurs next and is defined by a rapid phase of muscular contraction to propel the bolus through the upper esophageal sphincter and into the esophagus. In the last stage, the esophageal stage, the bolus progresses towards the stomach. The structures involved in the physiological act of swallowing develop early in fetal life, around the beginning of week 4 of embryological development. Around this time, the branchial or pharyngeal arches begin to form and will later give rise to the mature adult structures pertinent to swallowing. Multiple nerves are implicated in the act of swallowing. The primary nerves involved include the mandibular branch of the trigeminal nerve, the glossopharyngeal nerve, the vagus, and the hypoglossus nerve. And in addition, the ansa cervicalis, which is part of the plexus cervicalis, and the recurrent laryngeal nerves. Pharyngeal sensation is achieved chiefly via the glossopharyngeal nerve, and the upper esophagus is innervated by the vagal nerve. Swallowing is a highly regulated and coordinated physiological act, and this slide shows the numerous muscles which are involved. During the oropharyngeal phase, respiratory safety has to be safeguarded in order to avoid risk of aspiration and consequently risk of an aspiration pneumonia. Swallowing needs to be efficacious for sufficient nutrition and hydration. And finally, we need to take into account that quality of life is dependent on these two tasks. This is a slide which shows the symptoms of swallowing difficulty. I will come back to that later, but dysphagia often goes unnoticed. So the doctor has to specifically raise the questions about the speed of eating, about how the patient navigates food in the mouth, whether there are difficulties with chewing the food, to initiate a swallow, whether the patient perceives that food is sticking in the throat, whether he or she is drooling or has excessive sialorrhea, whether the food comes through the nose, if the patient coughs or chokes during swallowing. Because if this is the case, there is a risk of recurrent aspirations and consequently aspiration pneumonia, and also malnutrition and dehydration. It is not only often under-recognized by the patient, but also by the doctors. And this is a very nice quote from Jörg Patrick Stubchen, neurologist from South Africa, who did a radiological and manometric study of the pharynx and esophagus in patients with facioscapular humeral muscular dystrophy. And he states disorders of deglutition, swallowing, are probably under-recognized in patients with muscle disease. Patients without complaints of deglutition are usually not evaluated for a swallowing disorder. Therefore, subclinical swallowing problems may be overlooked. And he's right about it, and I will show you that in different cases. How do we assess whether a patient has swallowing difficulty? Well, there are several patient-related outcome measures, which are listed on this slide. The Sydney Swallow Questionnaire, the Swallowing Quality of Life, the Neuromuscular Disease Swallowing Status Scale, and the EAT-10. And the Swallowing Quality of Life Scale and the EAT-10 are the most frequently used scales. However, only recently there were questions about the reliability and the validity of these scores. Cordier et al. Performed rush analysis on both scales, and he found in the SwalQual, which was described as a valid and a reliable tool according to classic test theory, that using item response theory, rush analysis showed that there were unpredictable item responses and redundancy at the individual level. And with regard to EAT-10, which is a self-administered questionnaire, also validated, rush analysis indicated that this scale has significant weaknesses in structural validity and internal consistency. The other two scales have as yet not been subjected to a rush analysis, but this is really a problem we have to face. There are also bedside tests. Bedside tests to assess drinking and eating. Some clinicians prefer to begin trials with 5 ml volumes of water, gradually increasing the volume before moving to thicker consistencies. And the rationale is that water, if aspirated, will be absorbed into the lungs without the immediate risk for the development of an aspiration pneumonia. Other clinicians, however, prefer to start with thickened consistencies so as to reduce the risk for aspiration. And with regard to eating a cracker, trial feeding is only considered an appropriate management strategy if the patient has an adequate voluntary cough and is able to manage his or her own secretions. Finally, there are instrumental tests, as depicted on this slide. Both golden standard assessments, the videofluoroscopic swallowing study and the fiber optic endoscopic evaluation of swallowing, might be gold standard because they can diagnose aspiration and other physiological problems in the pharyngeal phase. However, access to instrumental assessment may be restricted in countries with low resources, and no international consensus exists regarding which physioperceptual or software-based measures to use for analysis of these video recordings. And moreover, there is insufficient psychometric evidence to recommend any individual measure as valid and reliable to interpret VFS and FEES recordings. This is the list of diseases which can be associated with prominent dysphagia during the course of the disease, or which can present with swallowing difficulties. Motor neuron diseases, peripheral neuropathy, neuromuscular junction disorders, and the longest list are the myopathies associated with swallowing difficulty. I will start with ALS. Obviously, in progressive muscular atrophy, dysphagia can also be a prominent symptom, but usually in advanced cases. It never is a presenting symptoms. Whereas this is the case in ALS, as you can see, in 30 to 40% of the cases, there is a bulbar onset dysphagia and dysarthria. And in only a very small percentage, there is respiratory involvement as presenting signs, and by far the majority has a spinal onset of disease. The bulbar onset is often associated with atrophy of the tongue, as you can see here in the gentleman, the picture of the gentleman, and there are nearly always fasciculations. Why is this important? Because if there is bulbar onset in ALS, it determines the prognosis, as you can see here on the Kaplan-Meier curve. Bulbar onset of ALS means that there is a reduced life expectancy. This guy shows oral fasciculations, which is a pathognomonic symptom or sign, actually, I should say, in bulbospinal muscular atrophy, Kennedy syndrome, which has a X-linked recessive inheritance and is caused by repeats in the androgen receptor gene. A natural history study on a huge cohort of patients showed that in more than 10% of the cases, dysphagia may be the initial symptom. And during the disease, all patients develop dysphagia, which is not necessarily related to the limb and truncal weakness. And dysphagia is known to reduce life expectancy in Kennedy syndrome, so it requires appropriate management. A very, very rare disease is the riboflavin transporter deficiency, and formerly known as Brown-Violetto van Laere or Facio-Londe syndrome. It has an autosomal recessive inheritance and is caused by variants in genes which encode for the riboflavin transporter. It is clinically characterized by bulbar palsy, dysphagia, and dysarthria, sensory neural deafness, and facial weakness. And in addition, there may be respiratory insufficiency and optic neuropathy. The age at onset can be variable, but usually it is diagnosed in children. Why is it so important to recognize? Because it's a treatable disease. If untreated, there is a fatal outcome, but riboflavin supplementation is life saving, and obviously the sooner the treatment starts, the better. Another motor neuron disease is Postpolio syndrome, which occurs in quite a number of patients, usually between the 60 and 75% of the patients who have had acute polio in the past. And quite a while ago, we performed a video fluorographic follow-up study in patients, in postpolio patients, and 43 postpolio patients were found to have abnormalities on this video fluorographic follow-up study. And 4 out of these 8 had acute bulbar polio. This is the first case that I've seen and which I would like to discuss with you. A male patient who was referred at age 59 years because of swallowing difficulty. When we took the history, he said that actually he had swallowing difficulty from childhood onwards, but it increased over time. He had difficulty swallowing, in particular, of solid food and was choking on saliva. But the history also mentioned that he suffered from cramping of the throat, which felt like choking, and that was very frightening. It occurred at night, but gradually also during daytime. His medical history is quite interesting because he told us that in 1956, at age 5, he had had bulbar polio after a trigger. Tonsillectomy is a well-known trigger for bulbar polio, and he had to be artificially ventilated in an iron lung. He was tracheostomized, had a feeding tube, and underwent myotomia of the upper sphincter of the esophagus. On examination, he had a hoarse voice, a weak cough, slight facial weakness, and weakness of the neck flexors. We asked the ENT specialist to perform an examination, and a paralytic focal cord on the right was found and stasis in the right sinus piriformis. So altogether, we diagnosed the postpolio syndrome in this patient, manifesting with progressive dysphagia and a laryngospasm due to intermittent weakness of vocal cord abductors. And he was treated accordingly, was first referred to a dietitian. There are also immune-mediated neuropathies, which are associated with swallowing difficulties. In the first place, Guillain-Barré syndrome, and especially those patients who are admitted to the ICU. More than 80% of these patients had dysphagia. Dysphagia also occurs in 30% of the cases with Miller-Fisher syndrome. And bulbar weakness also is a prominent feature of the pharyngeo-cervical brachial variant of Guillain-Barré syndrome. Neuromuscular junction disorders, a well-known cause of dysphagia. Let's first start with the most frequent form of myasthenia gravis. Myasthenia associated with antibodies against the acetylcholine receptor. Usually, well, let's say the majority of patients have ocular symptoms and signs at onset, but gradually that may change. 20% the myasthenia remains ocular, but at least 60% become generalized. And in that regard, dysphagia and dysarthria often occur. That's different in myasthenia gravis associated with MuSK antibodies, and I will come back to that later. And Lambert-Eaton myasthenic syndrome usually starts in the proximal muscles of the legs and may then ascend. So in advanced cases, lots of patients complain about dysphagia. This is a patient that was kindly, the video was kindly provided by my colleague Anneke van der Kooi, a 42-year-old female with a 1-year history of speech impairment and swallowing difficulty. And as you can see, she had a nasogastric tube. She refused to undergo a PAC installment. She also had external ophthalmoplegia, was nearly anarthric, had facial weakness because she's not able to close her mouth, and also generalized weakness, grade 3, and her vital capacity is reduced. You don't understand Dutch, but you can hear that she is nearly anarthric.
Wil ik een paar testjes erbij? Kijk eens naar mijn vinger, blijft u kijken.
Well, we don't want to have the ocular
Wordt van woord,
examination.
ja.
Well, this shows the ophthalmoplegia, and this shows that she has difficulty extending and raising her arms, and you can clearly see on both sides that she has finger extensor weakness. So she was subjected to, to some diagnostic test. First, a neostigmine test, and that dramatically improved her symptoms, as you can see. She is able to talk.
Ook wel voordat ze vraagt. Kijk, was het al antwoord.
And close her mouth. And she's able to raise her arms. And even able to laugh. The EMG showed a decrement, which is very typical of myasthenia gravis, and it always takes a while before the results of the antibodies come in, but she was found to have positive acetylcholine receptor antibodies. So in this patient, the dysphagia and dysarthria were presenting symptoms. This is quite common in patients with anti-MuSK myasthenia gravis, and bulbar impairment is found in up to 80% of the cases. They also have weakness of neck muscles, especially neck extensors, in relation to mild limb weakness. Mostly females are affected, as you can see, and I would discourage to do a neostigmine test in these patients. First, because it's not very sensitive, it's negative in 40% of the cases, and it can be very risky. Patients who complain about breathlessness, if you subject them to the neostigmine test, they might end up at the emergency department because they might stop breathing due to the neostigmine administration. We stick with myasthenia, but this time neonatal myasthenia gravis, which occurs in 10 to 20% of the mothers due to transplacental transmission of IgG antibodies. And it usually resolves within 1 month. It develops 1 to 3 days after delivery. The clinical picture is that of poor sucking and swallowing, generalized hypotonia, and sometimes also respiratory distress. There is no relationship with the severity of the myasthenia gravis of the mother. And as you can see, there are several treatment measures. This is a video which was taken from the website of neurology, from a paper by Erik Nix et al., who is a child neurologist in the Netherlands in Leiden. And he shows the neurological examination on day 3 of a boy who was the son of a patient with generalized myasthenia gravis, which was well under control with medication. 8 hours after birth, drinking became difficult, and after 16 hours, he showed mild generalized hypertonia with diminished facial expression and a weak cry. 32 hours after birth, examination showed paucity of general movements, a tent-shaped mouth, and chest retractions. And after 10 minutes of examination, weakness increased, leading to an immobile frog position. He was treated with cholinesterase, and the weakness resolved in a couple of days. The last neuromuscular junction disorder are the congenital myasthenic syndrome, which is caused by various gene mutations affecting the neuromuscular junction structure and function. You see them in the cartoon. And the clinical features include impaired sucking, swallowing difficulty, dysarthria, and also external ophthalmoplegia, facial weakness, respiratory insufficiency, hypotonia, and limb weakness can be found. And this is the list of myopathies which may manifest with dysphagia. Oculopharyngeal myotonic dystrophy, mitochondrial myopathies, congenital myopathy, Duchenne muscular dystrophy, Pompous disease, FSHD, and finally myositis. And I'm going to present cases of each of these diagnoses. I will start with the case who was referred at age 75 years old. He was 75 years old, and he was referred because he was suspected to have ALS. He developed gait difficulty, the weakness of his left leg, and at the same time he complained about weakness of trunk muscles and arms. He had a hoarse voice and swallowing difficulty, and admitted when we took the history to have progressive speech and swallowing difficulty since about 20 years. His previous history mentioned cataract surgery at age 74 and 75 years. And when we asked for the family history, he said that mother may have had a muscle disease. He could not give any specific details. This is the patient who has facial weakness, as you can see, at rest, but also when he's trying to close his eyes and showing his teeth. He had ptosis. He did not have overt external ophthalmoplegia, a weak cuff, moderate generalized atrophy and weakness, and otherwise the neurological examination was normal except for a left plantar response extensor. And I think that that was the reason that he was suspected of having ALS. The EMG first showed neurogenic abnormalities, but we performed a repeat EMG and that appeared to be myopathic, and his CK was not very relevant, slightly elevated. Video fluoroscopy showed silent aspiration. We considered a diagnosis of oculopharyngeal muscular dystrophy very likely because of the ptosis, the swallowing difficulty, and he did not have any fluctuating weakness. The history was of a long duration, and perhaps there was a positive family history with his mother who was said to have a muscle disease. So we went straight for analysis of the DNA analysis aimed at finding a expansion in the PAPBN1 gene, and indeed that was the case, so we could diagnose him with oculopharyngeal muscular dystrophy. And this is very important because he has children who wanted to have genetic counseling for this. In oculopharyngeal muscular dystrophy, here you see another patient with more prominent ptosis. Dysphagia is the first symptom in more than 30% of the cases, and mainly to solid food. They have a sense of throat blockade and coughing and choking during eating, and that alters their eating habits. They can only take small bites, and eating time is considerably prolonged usually. Because of the progressive nature of dysphagia, therapeutic interventions are required within a mean of 8 years from onset. You see next to the picture of the patient a muscle biopsy, which shows rumped vacuoles. We used to do a muscle biopsy when the molecular genetic analysis was not possible, but we refrain now from doing a muscle biopsy. First, because it's very easy to do genetic DNA analysis, and second, because this is not a very sensitive findings. In quite a number of cases, rumped vacuoles are not present. And besides that, rumped vacuoles are non-specific, can be seen in other diseases as well. Myotonic dystrophy is often associated with dysphagia, swallowing difficulty, and probably already early in the disease. It is often unnoticed, and that may also be due to the cognitive changes of these patients. They complain, if you specifically ask them about increased duration of the mealtime, they often cough while drinking. They choke on food. The food and drink liquids may come through the nose. They have to take small bites, and that may lead to weight loss and to aspiration pneumonia. A questionnaire has been distributed amongst a huge cohort of myotonic dystrophy type 1 patients, and also a considerable cohort of patients with myotonic dystrophy type 2. And as you can see on the bar chart, dysphagia is also found in about 1/3 of the cases of myotonic dystrophy type 2. And they also have other gastrointestinal manifestations, such as acid reflux and constipation, which is even more frequently seen in myotonic dystrophy type 2. Also, in congenital myotonic dystrophy, the oral function is impaired. There has been an exploratory study on the orofacial function in 41 children with congenital myotonic dystrophy, and that has been compared with healthy controls. And you can see here that due to weakness of the lip, the tongue, and the jaw, there is impaired difficulty with solid food, but also with liquids. This patient was referred to us at age 39 years, and she was referred because of limb girdle weakness. And her previous history included congenital deafness, infantile encephalopathy, pseudo-obstruction syndrome, and she had a PEG installed because of dysphagia. It has taken a long time before she was referred, because her treating physicians thought that nearly all her symptoms and signs were due to the infantile encephalopathy. But when we saw the patient who had external ophthalmoplegia, facies myopathica, limb girdle weakness, and of course the PEG, as you can see, we considered a mitochondrial myopathy very likely. Her muscle biopsy showed ragged red fibers, as you can see here, and she was found to have a MELAS mutation. Of note, her mother also has limb girdle weakness and had the same mutation. In mitochondrial myopathies, according to this systematic review by Visser and Frank, there are frequent gastrointestinal manifestations, as you can see here, and dysphagia is one of them. So now we proceed to congenital myopathies. And this is a picture taken from a paper, and this picture was kindly provided by Professor Peter Barth. And you see here the myotube like fibers in the muscle biopsy, and here in the Nemelin myopathy, the rods. In a study by Cassandrini et al., it is clear that there are respiratory, feeding, and orthopedic procedures in these patients. ACTA1 and Nemulin are both genes that cause Nemelin myopathy, and MTM1 is the causative gene of myotubular myopathy. And we are going to look at this pink bar, which represents whether the patient has a gastrostomy or a ionostomy. And you can see that more than 50% of the patients, nearly 60% of the patients in Nemelin myopathy have dysphagia, and almost 75% of the myotubular myopathy patients. Even in Duchenne muscular dystrophy, although limb muscle weakness and respiratory muscle weakness are more prominent, but even in this disease, swallowing difficulty can be very prominent due to increased tongue thickness. So that regards the oral phase. And that occurs in early non-ambulatory patients, as has been found by a group in Nijmegen. And these patients have more problems with swallowing of semi-solid and solid food than thin liquids, especially in advanced stages. The same holds true, but to a lesser extent, for advanced cases of Becker muscular dystrophy. Pompe disease. As you know, there are two broad subtypes, infantile onset, and you see the movie in the upper panel, kindly provided by Dr. Ans van der Ploeg. This is an untreated patient who is severely hypotonic, and there is late onset Pompe disease, and these are the pictures of such a patient. Pompe disease is a glycogen storage disease. There is accumulation of glycogen in the lysosomes due to deficiency of GAA. And dysphagia also occurs in Pompe disease, both in infantile onset form and in the late onset form. There was a study on 13 subjects, and all these patients were dysphagic. They had a weak suck in 70%, and there were all sorts of other symptoms and signs. And there was even silent aspiration or penetration in more than 75%. Of note, enzyme replacement therapy, which is the therapy for infantile Pompe disease, can be beneficial in a fair proportion of patients who were able to get back to autonomous feeding. But 1/3 of the patients with late onset Pompe disease also have dysphagia and have tongue weakness and tongue atrophy. And on an MRI, it's possible to see the atrophic tongue because it has a bright sign. Usually, facioscapulohumeral dystrophy patients do not complain about dysphagia. But the small wall assessment scale showed that more than 25% have symptoms in the sense of increased eating duration, the fear of choking, and fatigue during eating. So these patients have to be referred to a dietitian and followed up. And finally, dysphagia is not uncommon in myositis, both in inclusion body myositis, of which you see the clinical features here, atrophy of the quadriceps, finger flexor weakness, and dysphagia. It can be the presenting symptom in inclusion body myositis, and gradually about 60% develops dysphagia. But it can also be found in patients with other idiopathic inflammatory myopathies, like, for instance, immune-mediated necrotizing myopathy, which usually is a severe form of myositis. And here is the muscle biopsy showing necrotic muscle fibers, but no cell infiltrates. And this is a case of a patient who eventually has IBM, but it was quite a journey to establish a diagnosis. He was referred first by his GP to an ENT specialist because of progressive dysphagia since about 1 year. And it was only solid food which he had difficulty with. He told us that he coughed while eating and that choking occurred. And sometimes food came through the nose. He lost 7 kilograms over the past year. As I said, he was first referred to an ENT specialist and after that to a gastroenterologist who performed a video fluoroscopy. And first you see a normal video fluoroscopy, normal swallow, but the patient showed hypertrophy of the musculus cricopharyngeus, and there was an overflow of contrast, as you can see here, to the trachea. After that was found, the patient was referred to neurologists, and that is when we saw him. Well, we could not find anything else but his history of having swallowing difficulty. So he excluded ALS and myasthenia gravis and adopted a wait and see approach to which the patient agreed. The ENT specialist had treated him with Botox, and that was very effective for about 1 year. During one of the follow-up visits, the patient started to complain about fatigue in the legs, and he said, "It feels like I have run a marathon." So we did a skeletal muscle MRI, which was not contributory, did not show any abnormalities. We performed assessment of the anti-CNA1 of the antibodies, which are positive in a proportion of the patients with IBM. And we did a muscle biopsy, and that showed abnormalities which are characteristic of IBM. You can see here that in the endomysial space, there are inflammatory cells which invade an otherwise normally looking muscle fiber. So we diagnosed the patient with IBM, and obviously there was a follow-up. And during that follow-up, we noticed that he had progressive weakness of the deep finger flexors, not a pathognomonic, but very characteristic sign of patient with IBM, and the dysphagia was slowly progressive. These are all interventions for in the sense of management of dysphagia. As you can see, it varies between behavioral exercises to PEG and Botox. And the problem is that none of these treatments was evaluated by a long-term controlled and randomized size according to a Cochrane analysis, which was performed in 2016. But I would recommend that a patient has to be referred to a dietitian first, who discusses the diet and the eating habits, and also gives recommendation about posture. As in our patient, Botox was beneficial in the patient with IBM. Sometimes in IBM patients, because of the hypertrophy of the musculus cricopharyngeus, dilatation of the upper part of the esophagus is being done, or a myotomy, or a PEG. And in all the patients who present with dysphagia, oral health is crucial. And this brings me to the take-home messages. Dysphagia is a frequent feature in all sorts of neuromuscular disorders, as I have shown during this webinar. It may be the presenting symptom. It often goes unnoticed, both by the patient and the doctor. It may lead to undernutrition, aspiration pneumonia, and reduced quality of life. There are various assessment tools, like the PROMS, for instance, but there are some questions about reliability and validity. There are bedside tests for fluids and solids, and some instrumental tools. And unfortunately, management so far lacks evidence. And this completes my webinar. Now I will stop sharing.
Thank you very much, Marianne. Very nice explanation in very lay terms. You have a very advanced basic student that is Josep Cames, that I'm going to unmute if I reach him, and you will voice his question because it will be more interesting.
Yeah.
Please,
Do you have?
Josep, go ahead.
Yeah. Do you have any experience with cricopharyngeal myotomy for treatment of OPMD dysphagia? If yes, do you recommend it? No, I do not have any experience with that. What I do have is experience with a very good ENT specialist who is specialized in treating dysphagia in patients with neuromuscular disorders. And sometimes, as I've shown, there is no hard evidence which therapeutic intervention is the best. So sometimes they perform a myotomy. Sometimes they give Botox, but that has to be repeated, and unfortunately. So I personally do not have any experience with that.
Okay. So we don't have other questions, but I had some doubts myself when I was listening to you. So, when you explain the limitations of the scales that you use for dysphagia, and my question is, in clinical settings, so research settings, do you really use them, and are they useful for follow-up of the complaints or not?
No, I don't use them, but I think we have to do it. Also outside the research setting, the EAT-10, and as I mentioned, some work has to be done on that. But with the classical theory, it is a valid and reliable and very easy to perform a test, and it is an addition to the questions I showed about swallowing difficulty. So Zohar Argov and I wrote a narrative review on swallowing difficulty a couple of years ago, which was published in Neuromuscular Disorder, and we recommend to use especially this scale.
Mm-hmm. Good, excellent. So that's something we can all learn from. It's interesting that you've mentioned the bulbar polio, because as you imagine, many of our attendants don't even know that it existed, that it was a thing. It's a very, very vulgar form of neurogenic bulbar palsy nowadays, as you imagine. So do you want to say anything about how do you switch from dysphagia from being neurogenic, neuromuscular junction, muscular, or even pseudobulbar, so coming from cerebral diffuse visions?
I come again. I don't quite get.
So what's the rule of thumb in terms of difference of assessment?
I see.
When you come
Yeah, well, actually, I think that history taking and clinical examination is key. That gives that gives you the first thoughts about the diagnosis. And you mentioned polio. In the Netherlands, we have quite a number of patients who have not been vaccinated. And there are, I mean, we have about 70 million inhabitants, and about 250,000 of these patients live in what we call the Bible Belt. And if a polio infection, if polio emerges, and it does, I mean, there have been cases described in the United States, for instance, these patients may acquire polio. We've had outbreaks in the 70s and in the 90s. So we still have quite a number of patients who may develop post-polio syndrome, and if they have had a bulbar polio, they might complain about swallowing difficulty. Well, yes, well, ALS, obviously, the clinical examination is very helpful with pathological reflexes and fasciculations. In polio, I would say that it's the clinical history. And usually these patients have, well, not in our case, because in his case, it was purely the bulbar muscles that were affected. But generally, in post-polio patients, they have sequelae of muscle weakness, which is usually asymmetric, and areflexia. Neuromuscular junction disorders are do have prominent fluctuating muscle weakness, except for the anti-MuSK myasthenia gravis. I must admit that I had a patient who presented with dysphagia, dysarthria, and a dropped head, and there was no fluctuation at all. So I thought that he was suffering from progressive muscular atrophy. Just in case I had his anti-MuSK antibodies assessed, and indeed he was suffering, which is quite exceptional as a male, suffering from anti-MuSK myasthenia gravis, and was treated accordingly. And then there are the myopathies, in which there may be very specific details which can help in establishing a diagnosis. Also in the clinical history, I showed the male with the oculopharyngeal muscular dystrophy who had ptosis and a long duration of illness, and a mother who was probably having a muscle disease, or in myositis, there's subacute onset. So I would say clinical history and clinical examination are key.
Excellent. You have another question from Josep Gamez. You can unmute yourself if you want, Joseph. It says that Spanish patients are reluctant to accept PEG or REG. He wants to know if you have the same problems in Netherlands in this case.
No, but I wonder why they are reluctant to undergo installment of PEG or REG. Could you clarify that? Give me more insight, Joseph?
Perhaps he's not able to connect.
Oh, okay.
Okay, so.
Well, we discussed that extensively with the patient, and not only do I have an ENT specialist whom we closely collaborate with, the same holds true for the gastroenterologist. So this is a gastroenterologist who knows what to discuss with patients with neuromuscular conditions. And obviously we had an ALS clinic. So the gastroenterologist had to discuss numerous times with ALS patients that actually a PEG was strictly indicated. And there are disadvantages with a nasogastric tube. It doesn't look very nice. It has to be renewed once in so many weeks. So no, we have not noticed any reluctance usually against such a therapeutic intervention. Oh, they prefer oral food despite, well, but that is still possible. That is why I was referring to a gastroenterologist with specific knowledge about neuromuscular diseases. I mean, having a PEG does not mean that you cannot have any food orally. You cannot have complete meals, but you can taste, you can have a few sips and a few bites.
Yeah. And so to finish, Capucine Trollet, if you want to unmute yourself and give us a testimony of your experience with cricopharyngeal myotomy that you know through Professor Jean-Jacques Sanguilly.
Yeah, can you hear me?
Yes, sure.
Yes,
Yeah,
perfect.
no,
Hello,
yeah. Hi. So I'm not a clinician, but I know that from the experience that we have with OPMD, they are very often referred for myotomy in France with these two ORL because it's quite efficient as well as for IBM patients, whereas it's not for other myotomy. So this was just a comment to the first question about experience with cricopharyngeal myotomy for treatment of OPMD dysphagia. I think this is quite, well, you can only do it once, but I think it's quite efficient at some point.
Yeah. Thank you. And you also mentioned that dilatation is being done in Quebec. And that shows that, you know, there are differences.
No, for sure. But I never know whether this is where you have the adequate surgeons to do this, whereas dilatation is maybe more practically feasible anywhere in the world compared to a myotomy, which is an open surgery.
Yeah, this gives me the opportunity, thank you, Capucine, that this professor whose name I forgot, Sanguilly, but this is the abbreviated version, and Zohar Argov and I and a couple of other people are going to, and Antonio knows that, are going to apply for a workshop, an ENMC workshop, and Capucine, you must be very familiar with that.
Yeah.
Aiming at making a standard of care, but also improving the diagnosis in patients with neuromuscular disorders associated with dysphagia. And this Professor Sanguilly was recommended to me by Zohar Argov, who has experience with collaborating with him with regard to OPMD. Zohar is an expert on this. And I hope that we can organize that workshop later this year.
Yeah, that would be great. I'm sure he would be happy to participate. I will let him know. He's in our team, so I will let him know.
Wonderful. Thank you very much. Yeah.
You're welcome.
So I think it's time now to thank you very much, Marianne, for your wonderful participation and this huge contribution for our educational efforts. And I hope also that you will be very soon back with other teams or the same team, whatever is hot at the moment. So thank you very much, and thank you all for being present. These will be available afterwards on our website as usual in the webinar section. Bye-bye.
Thank you. Bye-bye, Antonio. Thank you for your assistance.